Today we are all here. See, TB is a problem. TB is a disease which has been there for centuries, right? And in 1896 or 94, when the BCG, that was 1894, 1896, and BCG vaccine was by Pasteur, one scientist discovered. Then we came to know the cause of the TB. Everything has gone, and now it's almost a century old, right? Today we are still fighting TB, and TB is one of the leading causes of deaths, which was very ostracized, right? Supposing today I have a TB patient in my house, even my neighbors, they don't want to come to my house. I think you all know the social stigmatization. It has been there for a long time. But today, as we come to know more and more things about TB, the time has come when we have done lots of research in the field of medicine, in the field of diagnosis, in the field of sociology. TB, 50% now is taken by social work and sociology. It's a social disease. No more a medical disease. Today it's a social disease. So those things have come. So government of the whole world is fighting. It's not only in India or Nagaland. In Africa it is worse. Bangladesh is worse. You go to Thailand, it is again the same. So in most of the not developed worlds, the developing worlds or underdeveloped countries, developing countries and underdeveloped countries, the burden of TB is very, very huge. And after they did so much of research, they have come to know that it mainly is very common, and it is generally TB is very prevalent among the lower socio-economic strata people. People who are not nutritionally well-fed, nutritional, and people who don't have a proper income group, the lower income group, and people who don't have a really hygienic and well sanitized house, properly lit rooms, or poor unhygienic conditions. These are the places where TB is still very prevalent, and it is mainly so in the underdeveloped and developing world. Now, you all are very well aware about SDG, Sustainable Development Goals, right? SDG 2030, especially in the planning department, finance department, is very common, right? SDG 2030, SDG 2030. So, in the Sustainable Development Goal of WHO, I think it's WHO, right? One of the components is to eliminate TB from the face of this world, right? That is one of the components of SDG. 1, 2, 3, 4, is it up to 30, 40 points. One is to eliminate TB from the face of this world. Eliminate TB means you cannot throw away TB from this world. Eradicate the possible, but eliminate is possible. Eliminate means you bring down the level of infection to such a low, level of infection that it doesn't, it ceases to be a burden to the society. Infection will be there for high risk groups, for people with some preconditions in the body, but it will not become a social disease. So that is the goal of SDG, to bring down the level of infection to, I think it is 44 per lakh population for our country. Now, when SDG goal was pronounced in Geneva, or I don't know wherever in Geneva, our Honorable Prime Minister Narendra Modi, he went with an ambitious plan, I would say even over ambitious plan, to eliminate TB from India in 2025. World wants to eliminate in 2030. But our Prime Minister said we can do it in 2025. That's how we are today. Today is 2022. We have just 3 years more. Not 3 years, 2 years more. Because 2024 December day khatam ho gayi na. Right? So we have another 2 years. In 2 years, do you think it can be eliminated? No. But that's what I think. But if we put in every effort, it is possible. So, with the aim to eliminate TB from the face of India, Narendra Modi, our Honorable Prime Minister, has said we will eliminate TB from India in 2025. And after that, so many activities have come. If I keep on naming the activities, the whole day will take for me to explain to you. But one of the activities which, the last one, that is the latest one, I have the letter with me, I'll give it to you, I'll give you also, which just came 2 months back, is community support for TB patients. Community support for TB patients. That is one of the activities now. Now, see, Government of India has tried to stop selling of TB medicines in the pharmacy because they are supplying the best medicines. You can come and see my store. You can come and go to any TB centers in Nagaland. We have the best TB medicines and the tuberculosis drug medicines, which is supplied free of cost by the Government of India. Right? We have the best diagnostic equipment. We have the TrueNet, we have the CBNet machines, which are very, very expensive. Government of India is giving them. Apart from that, Government of India is giving all whatever is possible. Government of India has pumped in. But maybe after from 2018 till today, they're saying that ये government से होने से नहीं होता. Just the government giving money will not work. We need the community support. That is one of the last and which is the recent one. So today we are going to talk on community support for the TB patients. And in addition to welcoming you all as our partners in the fight against TB, we would like you to pass on the message to the people that, look, if I, as Dr. Tiasunup, can adopt one TB patient, adopt means what? Medicine is free. Apart from that, they get this NPY that is coming from Government of India. Now, but they need nutrition, right? Any TB patient, apart from the medicine, he or she needs good nutritional support. So, if I, as a community, try to come forward to support one TB patient, that's a big thing. So, if each and every one of us, as individuals, one, as a society, one, as an NGO, one, as a faith-based organization, one, no, as Directorate or what is a Red Cross Society or Naga Mothers Association, Nagaland Baptist Church Council, or even as Kitty Baptist Church, for example, or UPC Church, Our Baptist Church. So if everybody comes together and puts in some effort, when the Government of India is also fighting, when the medical department is fighting with medicine, diagnosis, everything we are also doing. So, but then, apart from that, we also need to give them counseling. We need to give them moral support. We have to give them nutrition. That is what we are going to talk to them. Community support. So, with that few words, I welcome you all once again.
The SDG goal is 2030. Okay, but India has committed so India is saying that we will achieve that goal 5 years ahead of the SDG target. So the Prime Minister of India, the treatment, the public health actions, and also not forgetting the community support, the community engagement part. So it includes all those approaches. Disease that is caused by Mycobacterium tuberculosis, and of all the TB, of all the parts in the body, it mainly affects the lungs, TB. But having said that, it doesn't mean that it will not affect the other parts of the body. It affects almost every part of the body, except that it is said that it affects every part except the hair and the nails. new cases of TB annually is around 10 million. This is the report of Global TB Report 2020, and we also have 9, which is close to 10 million only. So the incidence of TB cases is 10 million, which in India is about 26 lakhs new cases. And when we compare, there is a distinction between TB infection and TB disease. So TB infection can be any one of us here also. Like if we have a family in the, if we have TB in the family, and if we are exposed to that family, side effects. So we also monitor those things. Incentives for the private practitioners. If the private practitioners notifies the patient, private practitioner test diagnose and notify to the nodal nodal officer at the district tuberculosis center. That is mandatory now. There is a gazette notification on that, 2018. So now it's mandatory and it has to be notified. Then the number that has been notified is 94% in 2017. But if you see 2020 and 2021, it has come down a little bit. Come down 72%. So let's see this slide. If you see over the years, 2017 from 2015 to 2019, the trend has been going good. Like it has shown an increasing trend. But because of COVID, 2022 nodal DRTB centers in Mohokchung and Kohima. So those has been converted to COVID-19 facility. And also, I think you also know. I think even some of you might be there in that health workforce. Even our workforce has been rostered for COVID-19 during those days. And our diagnostic machines also has been diverted for COVID-19 diagnosis. There were restriction of movement, and patients showing symptoms of TB also do not access care due to COVID fear. I think there are stories from the districts that if I give sputum for testing TB testing, some are scared that they will test for COVID also. So fearing those things that people don't access care. So what has the state done to mitigate those impacts? So monitoring and supervision at various levels. So we have those days we mostly have virtual interaction, but reviews are
today. The backbone of any TB therapy is isoniazid and rifampicin. So what you are talking about is CBNet testing, and in CBNet they diagnose it, and find out whether there is a resistance to rifampicin. Again, after that, we have another test called LPA that happens in Guwahati. In Nagaland, we don't have the lab. Then we go for INH resistance also. So like that, we have so many things. If you go to detail, even me as a doctor, I don't know many things. It's very, very complicated. But then, in short, for your knowledge, for your consumption, you should know preventive treatment. TB preventive treatment. Supposing I am having TB. All the people around me at home, my wife, my sons, my daughters, my servants, my drivers, anybody in my household will have to go for the TB preventive therapy. That is INH. I think so, the INH. No. But we are coming with another one now. So things are modifying now. Right? So the whole family is having TB medicine, you can imagine. And now in Nagaland, it has just taken up, it was just taken up 4 or 5 months back. So there are many patients, many parents or many relatives who are saying, "Are, amar bacha TB bimar hole ki baba rama dawai khao." That research is coming now. And even you and me also will do the same thing. Just because my wife is having TB, why should my children and myself also start eating the tablet? But mind you, for your knowledge, my wife, supposing she is having TB, she will either go for the 4 tablet combination or 7 tablet combination or 13 tablet combination according to her diagnosis. So she is going to have many tablets together. But the remaining of us at home, that is called the contacts of the TB patient. We will only go for 1 tablet that is called isoniazid.
You're talking about TB of the lungs, right?
TB of the lungs, right. TB of the pulmonary TB, right. So, yeah, again she is very, I think she has asked. The most infectious of all the TB is the pulmonary TB. Because the person, when he coughs, when he sneezes, when he talks, when he salivates, when he speaks, it's coming out from his lungs. Otherwise, if you are having bone TB, the chances of infecting someone else is very, very rare. If you are having skin TB or any other part, abdominal TB, except for the fluid, abdominal fluid, but coughing, sneezing will not affect others. So, the danger is in the pulmonary TB. Okay? So, with a few words, I think thank you, Dr. Collins.
Good that government of Nagaland has bought so many machines everywhere now. So that is one. And this is like CPNet and TrueNet, the basic principle is same. But the thing is, in CPNet, it's from outside. Like it's cartridge based, so it's also called gene expert. If you Google it, it's gene expert training, but we call it CPNet, cartridge based technology. So what they do is like in a cartridge, you can put the sputum there, process sputum, and it will give you a result in 2 hours. It will tell you if it is empty, if there is a rifampicin resistance. So you get both together. TrueNet is indigenously built in our country, and it will give you, it has 2 steps testing. So, firstly it will tell you if there is MTV, secondly it will tell you if there is rifampicin. If MTV is detected, we want to see rifampicin resistance or not. Like Sir was mentioning, it's the most important drug in the first line regimen. So we want to see first hand if it is resistant or not. Then active case finding, which I think we have missed that. So traditionally what we have done is we have done it upon people coming to the health facility, and then if they say I have cough, then I ask is it how many days? So if 2 weeks I go for sputum examination. Now we are moving towards then we have intensive case finding. For example, if intensive case means we are actively asking them. Now we are moving towards active case finding, where our health workers, be it NTV, want to bring their sputum to the testing facility